So welcome to this final session of the day. It's a great pleasure for me to introduce this session on the right ventricle, the right valves for the right ventricle. It's going to be a session sponsored by Venus Venus MedTech is one of the newest kids in town, let's say, at least in Europe, is entering the European and Western reality with a number of different tools. I've been also pretty lucky already to have hands-on experience on both the pulmonic valve and cardio valve, obviously. And today we are going to go through a very important stepwise approach in understanding the role of valve replacement technologies, both tricuspid and pulmonic valve, with experts who have been already involved in these procedures. So we will get information regarding the technical details, but also selection criteria and all the rest. So it's my privilege being the anchor person also to start already with my presentation, just to start with, and just to make a quick overview on the landscape of transcatheter tricuspid valve replacement. These are my conflicts, including the fact that I'm a consultant for Venus. And we all love transcatheter edge-to-edge repair. Tricuspid repair has been revolutionizing treatment of these patients with chronic isolated tricuspid regurgitation. These were patients who were really desperate, and we have solutions now. Unfortunately, this doesn't work in every patient. We learned, we're trying to push the limits at the moment, but still, there are many patients where this technology is suboptimal. For this reason, we need to find alternatives, and there are several alternatives. Among those, replacement plays an important role. Now, replacement can be achieved in two ways. One way is a non-orthotopic implantation of valves in the superior and inferior vena cava. Some of my colleagues on the podium have specific expertise and maybe have more details than I have. This is actually, Roy Loriero has been the first author of this publication, which is the first European registry on tric valve. The problem with non-orthotopic implantation is that actually you have to ventricularize the right atrium. And you see very nicely in this right picture what you observe very often. You have, obviously, you reduce the pressure in the splanchnic organs. You reduce the pressure in the superior and inferior vena cava area, but this has a cost on the right atrial pressures, and it actually is not really solving the issue of the volume overload, because these patients still have significant tricuspid regurgitation, and to maintain forward flow, they need to stay in volume overload, and somehow you need to accept some degree of low cardiac output. So obviously there are some advantages of non-orthotopic implantation, which include the independence from some anatomical constraints. They are very easy to use. So to some extent, we have seen that many centers who are not so expert, they start using these devices, I would say, without probably the best indications. And there is no need for special advanced imaging. So they are simpler. But the disadvantages are there. In the ventricularization of the right atrium, the interaction between the right and the left ventricle, particularly in the end-stage situation, may bring to even lower cardiac output, and still minimal impact on the volume overload and tricuspid regurgitation reduction, which is somehow achieved as well, because anyhow, it's like an Hufnagel concept in the right side, but still, not the real solution for these patients, in my opinion. Because what is the real solution? What we want to achieve with replacement is to really abolish tricuspid regurgitation once and forever. And by doing this, we want to achieve also the main goal, which is to abolish the volume overload and induce the reverse remodeling. These are data which are now being collected in different trials. These are data collected with a trial with in the Edwards devices. But still, this is what we see in every patient we are treated also with our devices in cardiac. We see the same. Cardiac is a surgical-like
system insertion is performed through the femoral vein over
device,
an extra stiff guide wire,
which can be implanted very easily. It is basically self-centering and self-positioning in the tricuspid annulus, and is a very simple procedure. There will be more opportunity to see this in real practice, so I will not bother you with this animation, but just to mention, is a very simple, straightforward procedure compared to valve replacement. We did the first in man some time ago. It's about a little bit more than 1 year ago, 1.5 years ago, and now we are collecting more and more cases, and I can again confirm the predictability, the simplicity of use in those patients who are good candidates. Obviously, this is not the only device which is available and is now in the R&D. There are other devices. Not all of these orthotopic devices have a classical fixation. There are some out-of-the-box ideas, and some of them are missing in this picture. But again, I want to share with you what is the knowledge at the moment. The TriShand trial has been collecting the largest number now in the literature. More than 100 patients have been treated, and these are patients who are obviously very similar to the trials in valve repair. What is very important is the low risk of these procedures. Similar to tricuspid repair, replacement can be achieved with low risk, very low MACE risk. There has been some degree of need for pacemaker, but don't forget these are also elderly patients who may have this as a problem. And obviously what you obtain in these patients is a significant reduction in TR severity and reverse remodeling. Now, there are some limitations. We should not make it the message too easy. Still, we're talking about devices which are in the R&D. These limitations will be solved by iterations and by implementing best clinical practice, and this is somehow the reason why we are here and the reason why we discuss all together with those who have been able to have hands-on experience on these devices. So with this, I'd like to introduce the panel here and the experts, really big experts. Roy Loriero, Esteves Loriero from Spain, Scott Lim, just coming now from the US, or he came yesterday?
Just yesterday.
Just yesterday. Okay. Neil Pham is another great guy who has a lot of experience with different replacement devices, almost more than 3 or 4. Being very Georg, this is there is no discussion that the Georg is in Europe has been instrumental for developing the tricuspid interventions, and obviously Felix is one of those guys who has a double position. He's an imager interventionist, so very important also for our discussion today. So without further delay, Georg, you can take the floor. I give you the clicker.
Well, thank you very much, Francesco, for this nice introduction. So these are my potential conflicts of interest. So the topic is that it's about replacement versus repair, or an initial discussion about this. There will be some redundancy to the previous presentation, but I think that will not harm. These are the guidelines, the recent guidelines looking at TR treatment, and to make a long story very short, is there is not a lot of place for open heart surgery in treating a functional tricuspid regurgitation, especially isolated functional tricuspid regurgitation. Therefore, I will refer only to transcatheter approaches of TR improvement. And what do we have? We have repair measures, as Francesco already pointed out, and I will only show you 2 devices which have been improved, which are in the clinical arena. And then we have, of course, replacement, and how can we somehow evaluate both against each other if we can at the current state. So you have seen such a slide before. This is the first device I would like to start with. It's a repair device. It's an annuloplasty device, and you can see on the right upper corner that with the cardioband you can nicely reduce tricuspid regurgitation, but in a small, very highly selected patient group, and admittedly in a small patient group, as you can see here. But still, there is reduction to moderate or less TR in roughly about 70% of the patient, and that is also followed by clinical improvement. You can see that in the bottom of the slide. But there are issues with this device and this procedure. For example, in approximately 50% of the patients, the annulus is just too large to accommodate the implant, so there are screen outs currently, at least in our patient population. It's a complex procedure. We need additional iterations of the device. You need complex imaging approaches, so it's not an easy procedure, and it can easily take you 2 to 3 hours to do this procedure properly. And then there are, again, other issues which may prevent success of an annuloplasty device. One is tenting or tethering of the leaflets. We are treating these patients who are far gone, have RV ventricular dilation, and they have a lot of tenting. And this is data from our own cohort showing you that roughly in 1/3 or even almost 1/2 of the patients, you have tenting above 10 millimeters, and these are no good candidates for an annuloplasty device. They will still have a severe TR after the procedure in most of the cases. Pacemaker-induced TR is another enemy of an annuloplasty device, if you will. This is, again, own data. We see about 10% in which the leaflet is really pinched by the lead to the annulus, but this is variable. In some other registries, it's about 30%. So this, again, prevents a successful annuloplasty repair of the tricuspid. The second device I would like to discuss briefly with you, Francesco touched upon this already, is the leaflet device. And here, for example, the TriClip device. You could also, of course, mention the Pascal device. And this is data from the TriLuminate study. And if you look on the right side, on the left side, there is a nice reduction from severe in yellow to torrential TR down in 70% of the cases to moderate or less TR in this greenish color after 1 and also after 2 years. But there is 30%, as rightly pointed out by Francesco, there are 30% left with torrential, massive, or severe tricuspid regurgitation. There is improvement in the clinical situation, as you can see on the right side. What is extremely important to mention with this device, we cannot treat every patient properly, but there is an extreme safety. This is TriLuminate data, and this has been mirrored by countless other registries and post-marketing surveillances. There is no cardiovascular mortality whatsoever in this type of patient. So virtually you can do this procedure without harming the patient, which is a really strong argument for this type of technique. But there are issues which can preclude a successful leaflet-to-leaflet approach. For example, also the leaflet configuration. Only about 1/2 or 60% of the patient we have this favorable free leaflet design, as you can see here, and also on our own data on the right side. In all the other cases, almost half of the cases, you have 4 leaflets, you have more indentations, and that makes it not so easy to do this procedure. And Asushi Sugiura also looked at this systematically. And if you look at this blue and this red bar, the blue bar are free leaflet configured tricuspid patients. There, most of the patient got off the procedure, 80% of the patient without a severe TR. But if you have more than 3 leaflets, it's not so easy to get the patient out of the hospital with not severe tricuspid regurgitation. That comes without saying, because you have more indentations, more commissures to cover, which you can spread open with the leaflet device. And then you have these large gaps. Probably about 20% of the patients do have these large gaps above 10 millimeters. We recommend to do gaps up to 8.5 millimeter in a recent consensus paper, but some of them have even larger gaps. And if you look at the subgroup analysis of the triluminate study, on the very right side are the patients who did go into the study with torrential TR. And in these patients, we had success with moderate or less TR in only 40% of the candidates. So it is difficult to treat this torrential patient, these far-gone patients, with an edge-to-edge device. And if you look at the triluminate pivotal study, these are the run-in data. Again, you have 30% of patients getting off the hospital with severe or even more tricuspid regurgitation. And this seems to matter if you look at a post-hoc analysis of the tri-valve registry. This blue is procedural success, less than TR2, and the red Kaplan-Meier more, so TR3 or 4. You can easily appreciate that there is poor prognosis associated with residual TR, similarly to mild regurgitation. So we need other options, and one option, of course, is a replacement. And there are 2 fundamental characteristics I would like to point out. First of all, the ease of use. Usually it's an easy procedure which takes you 30 to 60 minutes if you have a nice pre-selection, of course. And the second characteristic I would like to point out is on the right lower corner. You usually end up without TR in comparison to a repair measure you may use in your TR patients. And the only significant or the only systematic data you have seen that so far we have are coming from the TRISCEND study, and just concentrate on the right side. There you can see that most of the patients entered the study with severe torrential or massive TR, and after the procedure, in almost every patient, TR was almost completely gone. So this is fantastic in terms of efficacy, but there are some safety signals, at least if you compare it to a repair, and we are here to discuss that also. You have more bleeding, you have more thrombosis, you have some more cardiovascular deaths. The data are pretty encouraging, but they are not as good as with a leaflet device, for example. We have to admit this, and we have to work on this. And therefore, I would like to finish with these open questions. First of all, right now we don't know what the impact of repair or replacement in the tricuspid space is on outcomes, so we have to wait for the pivotal data. We don't know whether TR0 or 1 is really the general treatment goal. I would guess yes. But then there is the next question, of course, how many patients can we probably treat with a repair device? And I would think, at least from my cohort, in 30% of the cases, we're not going to be well off, or 40% of the cases, with a repair device. And then another question, which has also been posed by Francesco already: to which extent RV dysfunction is acceptable for a replacement device? So the keyword is here afterload mismatch. Right now we are treating highly selected patients in the replacement studies, so we have to find out in the future. Then anticoagulation is an issue because we have thrombosis. Same time, these patients have high bleeding issues, high bleeding complications, GI issues, so we need to work on this also. Durability, obviously, is a problem. And pacemaker. Pacemaker is a two-sided problem. First of all, it may preclude a repair measure. On the other hand, it may be a a side effect of a replacement device. If you have a self-expandable replacement device, considering the proximity of the AV node in the tricuspid annulus, it may cause also pacemaker implantations. So thank you very much for your attention.
Thank you. Thank you, Georg. Thank you, Georg. You just mentioned that not all patients are candidates. Let's see, Felix, if you can clarify who can be candidate for tricuspid replacement with cardio valve then.
Yeah. Also, welcome from my side. I have the honor to present data from the cardiovalve compassionate use cases. So this is really a strong slide, and you should all be focusing very closely. This is 20 patients that have been treated. I'm actually missing the most important information, that was mortality, and you obviously all want to know or interested that only 2 of these patients did not survive the 30-day follow-up period, and be conscious that this is first-in-man patients. And I was told that these 2 patients were very sick in the first place. One died very early, and the other one, a 90-year-old, died 14 days after the procedure, and all others came through very well. Left bottom, you see the sizes of the cardiovalves that were implanted in this population, and you can tell that the XL, so the very big prosthesis, was implanted in 70% of all cases. This is TR reduction. You may miss a dark green bar telling you the number of patients that did not have any regurgitation at all. So green is none and mild mixed, but you can easily tell that the great majority of the patients did not have more than mild TR. And here you can see that table I was missing on the first slide. Also interesting is one case had to be re-intervented due to a valve displacement in a patient that was found to have a flailing leaflet on the table. So it was considered to be functional TR, but turned out not to be. In this slide we've seen, I think this is the most fascinating signal we get from valve replacement, that taking away the volume load significantly reduces RV volume. So what is ahead is the TARGET study, an EFS trial that systematically wants to follow up patients undergoing cardiovalve tricuspid valve replacement. This is prospective single-arm, open-label, multi-center registry. A total of 100 subjects is supposed to be enrolled at up to 30 investigational sites in Europe and the US. And who are the target patients? It's symptomatic subjects, obviously, with more or equal to severe tricuspid regurgitation, who are being followed up to 5 years after the procedure. Primary endpoint is TR reduction to less than grade 2 and freedom from major device or procedure-related adverse events at 30 days. This is a classical list of secondary endpoints you are all familiar with: all-cause mortality, heart failure hospitalization rate, and so forth. There's really none that sticks out from different trials. Screening process is what you would expect. Patients need to be at least 18 years of age and not older than 85. That's going to be a critical border, maybe. Then patients need to be in New York Heart Class 3 or 4, and left ventricular function cannot be below than 30. And obviously, morphologic criteria have to be fulfilled, as there's only a certain range of processes sizes available, but important to mention that CardioValve has the largest valve on the market under R&D right now. So from a very clinical prospect, what are the patients we are looking for this study? It's obviously not the ones that are very well treated by TEER. They rather do not qualify. So it's big gaps, as we have discussed in the last talk. It's significant leaflet tethering with coaptation depth way beyond 10 millimeters. It's short septal leaflets. So it's the ones that kind of fail the first screening process when you look at TEER possibility. That's a very regular way how these patients are going to be screened. They sign their informed consent, and then echo, transthoracic, and TEE, obviously, and a full cycle cardiac CT are uploaded. And then there's an internationally screening committee that decides on each and every patient whether all in- and exclusion criteria are fulfilled. Thank you for your attention.
Thank you. Thank you, Felix. So we have seen more or less what are the ideal candidates for the trial, and now we have a couple of cases from those who have been having some colleagues who have had hands-on experience. So Roy is the first.
Thank you. Thank you. So we are going to show a case we did some months ago in our hospital in Vigo. These are my conflict. So that to give you an idea what could be the potential candidates for the target study, is a 71-year-old female with severe rheumatic mitral and aortic stenosis that she underwent mitral and aortic valve replacement with metallic prosthetic valves back in 2001. She's in permanent AF. She has some prior transient ischemic attacks, but without any sequelae. She's now in functional class 2 with some ankle edema. She's on warfarin, furosemide, spironolactone, what was considered by the referring physician the optimal medical therapy. So here is the echo pictures. As you can see, there's a significant and large right ventricle with a huge gap between leaflets in the transthoracic echo. Metallic prostheses are normal in function, and if you look at the TEE pictures, you see a thickened leaflets with very relatively close papillary muscles, with a huge gap that you see also in the 3D imaging. That probably that reflects a rheumatic affection on the tricuspid valve as well. The rest of diagnostic tests, we did, of course, mandatory right heart catheterization with no pulmonary hypertension, normal wedge pressure, slightly decreased cardiac output, probably reflecting the effect of the TR, and increased right atrium pressures. In the laboratory analysis, slightly increased NT-proBNP, and the rest of the exploration was unremarkable. And we also performed, because we observe in the TTE echo some degree of right ventricular dysfunction, we want to make sure that the ventricular function was preserved enough to undergo the procedure. So we observe in the MRI a severely dilated right ventricle with moderately depressed right ventricular function. In this case, right ventricular ejection fraction was 39%. After discussing in the heart team meeting, we decided that the patient was at high risk for conventional surgery. It was a REDU 3 score, that is the new score we are using, is 8%, with moderate right ventricular dysfunction. Not a candidate for transcatheter tricuspid repair, as we mentioned before, the gap, the leaflets. So it was accepted after discussion for cardiovalve tricuspid implantation. One of the most important analyses for deciding if this valve can be implanted is CT scan. We need a full-length cycle CT scan, and in this case, perimeter annular dimension was 53, so it was suitable for XL valve that covers up to 55 millimeters. The dimensions from the annulus to the apex and to the lateral wall, the dimensions in the right atrium at the distance to the papillary muscles were okay for the valve implantation. And also very important, at least in this first generation, is that the angle, the offset angle from the IVC to the annulus was less than 20 degrees. That means that it's quite straightforward trajectory to the center of the valve. Now we're going to see a summary of the live case we performed back in April. Same presentation as the case. You see torrential TR with some degree of right ventricular dysfunction. So one of the main issues in the procedure is to place the wire in the correct position. The maneuver to do that is to use a steerable sheath and to advance a pigtail turning to get to avoid the chordal entrapment and place the pigtail in the apex of the right ventricle anterior to the anterior papillary muscle. It is important to avoid entrapment of the device with the chorda and subvalvular apparatus. Then you place a extra small safari wire in the apex, And the next step is to make sure that you have a chordal-free path with this wire. To make sure we are in a chordal-free path, we do a flossing with a 12-millimeter balloon, just going to and fro to make sure that we have free access to the wire. And then we insert the device. The device comes, as you see in the picture, with an inline sheath that has to be inserted all together in the vein of the patient. The access is surgical cut down. You see there Professor Maizano helping with the entering of the device. Once you put your inline sheath, that you can advance the device. The device has two knobs. First knob, the most anterior one, is the flexing one, so you have to advance fully flex almost all the time and pulling the wire in order to advance all the system into the right atrium and almost right ventricle. Once you are in that position, what you're going to do is to activate the second knob to increase your height over the tricuspid valve. And we do that because we need to open the legs, the ventricular legs, way above the tricuspid valve. We are just positioned, trying to maneuver the device to be the much center as possible. And when we are high enough over the tricuspid valve, actuating this knob that you are seeing in the picture, we are going to release the ventricular legs. Just in a while, that's coming. The device has an echo marker that tells you that you are quite above the tricuspid valve. Once the ventricular legs are open, what you have to do is to try to center the device, and once you are centered, you just advance the whole system into the right ventricle to be with your ventricular legs below the leaflets. You do that by pulling the wire and advancing the system, as you see in the video. Once you cross the valve, the next step is to retrieve the whole system to capture all the leaflets. You see us here, it takes some time to cross the valve. You want to do it smoothly and to be the maximum center of the valve. And once you are inside, then you retrieve your device as you do in edge to edge to capture the leaflets. And you have to make sure that all the leaflets are well above our ventricular legs. And you do this by analyzing with MPR TE, just to be sure that your device is capturing all the leaflets. One good thing of this device is that you have the 12 legs, but you don't have to capture in all of them. You can skip maybe one in the commissures, because you have this other portion. Once you have your leaflets inside and you are really close to the annulus, you drop the atrial flange and you do quite kind of sandwich with the leaflets and annulus, and then you completely deploy the ventricular part, and now the valve is functioning. You have to have some attention to retrieve the device to avoid entrapment with the valve itself. You have to close the two capsules that the device has hosting the valve in order to retrieve the system, and you have to be in the center all the time. If you follow the advice of all the cardiovalve colleagues, that is quite easy, but what you don't want to do is to dislodge the valve from the position. So you are slightly retrieving the device, always center. You maneuver, that's quite easy. And then you are completely out of the system. And this is the result we see in a while. Acutely, complete elimination of the tricuspid regurgitation with no paravalvular regurgitation, and no gradient. Gradient is 1 in this case. So we have some follow-up of this case that it was done back in April. So this is the acute result, and we can show you the 7-month echo result. You see there's no TR, there's perfect CT the valve, no paravalvular regurgitation, no gradient. Patient is doing really fine. She is in functional class 1 and really happy. And what is even more important is that we have seen a very important inverse remodeling in this patient. This is the 7-month CT scan. We have observed a 40% reduction in the end diastolic volume, 60% reduction in the end systolic volume, and an increase in the right ventricular ejection fraction. If I put you the picture side by side, for me it was really striking the incredible reduction in the dimensions of the right ventricle. You see, in the first picture before the procedure, left ventricle was completely pushed by the right ventricle, and now it's almost a normal heart. And this is really something that is really striking to me, and for sure it makes that this therapy works. So just to conclude, the implantation of this device is feasible for patients with symptomatic TR, and is associated with a reproducible significant elimination of TR and improvement in symptoms, and is a really promising therapy for TR patients. Thank you.
Thank you, Rodrigo. Thank you, Rodrigo. It's now time for Neil to share with us a challenging case. I'm not aware of what is a challenge, so let's see. Because not every day things are easy, eh?
Yeah, it's not always unicorns and butterflies. Okay, so challenging case. So 82-year-old man, torrential TR, not good for TR. He has some coronary disease. Importantly, he has secondary prevention ICD, which will become relevant, AFib. And annulus measured 55 millimeters, but the IVC offset angle was very low, so he was quite suitable for cardiovalve. So here's baseline TE. You can see the ICD lead is pretty much in the center of the valve. It's not affecting the valve function. So transgastric view, more of the same. So lead-induced TR is one of the best indications for doing tricuspid valve replacement, but you have to consider potential issues. The lead can interact with your delivery system, can block your access to the leaflets, it can create shadowing, you could dislodge the lead, you can have PVL, and there's a theoretical risk of endocarditis. So my approach to this, first, is the patient pacer dependent. If they're not, then just jail the lead. Sometimes lead extraction can be considered, but that's usually only to facilitate edge-to-edge. And if they are completely dependent, you need a backup, as has been discussed, so leadless pacemaker, CS lead mainly. And if you dislodge the lead and they're pacer dependent, you have to be ready to pace immediately during the case, usually with a Safari wire, but you could put temporary wire as well. So is the lead blocking your access to the target? Is the lead mobile, and is there some slack? If there is slack, you can actually mobilize the lead by snaring it or using a deflectable catheter, either from above or from below. And that's what we had to do in this case. So the first thing that happened with this case, you notice his aorta is both heavily calcified and very tortuous. You can see it's almost a 60-degree angle, and so the IVC is following the aorta, and getting the delivery system up through the IVC was somewhat challenging. We never lost our wire position, but once we got the delivery system into the heart, we realized that the wire is now on the septal side of this ICD lead rather than being lateral to it. And so we had concern that we could not grasp the lateral leaflets. So we decided, either we could bail out and reposition everything, which would be very cumbersome. We instead decided to use an Agilis catheter to mobilize the lead and push it posterior and lateral, and that's what we're doing here. So here we have contact with the lead. This is from the left femoral vein, and we just gently pull down on the ICD lead, and you can see because there was slack, it could be mobilized. And then subsequent to that, we maintained the tension on the lead, and we were able to access the valve very nicely, all segments. So that's what's shown here with the MPR. You can see the lead is off to the side, close to posterior septal commissure, and we have very nice coplanar approach. So leaflet capture, as has been previously shown, of all segments. We pull up to the annulus, and then we gently release the lead, and it went between the ventricular legs, and then we deploy the valve. Now you can see the course of the lead is somewhat interesting. It's going sort of posterior and then septal. But there was no acute change in the lead position, and we tested the impedance and thresholds, and they were fine. And abolished TR, as you would hope. So he went home. And like I said, things were fine at first. 30-day follow-up, he's feeling better, and there's no TR. We're starting to cut back on diuretics. The one thing that often happens with TTVR patients is if you eliminate TR, you often reduce, and in some patients, eliminate the need for diuretics, which from a quality of life point of view is huge. However, 4 months post-TTVR, he has syncope. Fortunately, he did not have cardiac arrest, but he had intermittent failure to capture. And this was simply treated by increasing the pacing output. But what was noticed on interrogation was an increase in threshold and a decrease in impedance, despite there being no obvious lead dislodgement, and the echo was the same. It just highlights the need for very close follow-up with these patients if you're going to jail the lead. At 6-month follow-up, he's doing great. Stable ICD function, stable valve function. He's golfing. So in summary, many patients have leads. TTVR is a definitive solution. Leads can be repositioned with deflectable catheters carefully, and I think close follow-up is required to make sure that the device continues to function. And I'll stop there.
Thank you, Neil. We have a short time for discussion. I'd like to involve Scott. I mean, you've been watching all this, and the question is very simple. How much you need a replacement in your toolbox?
You know, I think we're still learning about how to answer the whole question of need. But certainly, just the other week, I did a repair case that took me nearly 3 hours, and I followed it by a replacement case, which took me 26 minutes. And I think all of us value a certain amount of efficiency, and we have to balance that with several of the unanswered questions that Jörg brought up about anticoagulation and durability and so forth. I think ultimately there's going to be a room and a need for both, and whether it's those cases that we feel we've got good imaging and the TR is only 3+ that would go to more repair technologies, and those that where the replacement technologies will shine more, where perhaps those with much wider gaps are harder to do by repair or may take us a lot longer. Although certainly we still have to learn about the anticoagulation and other issues.
So, Rodrigo, you mentioned like clipping, whatever, transcatheter edge-to-edge like approach. So, for those who have never done this procedure, how difficult is for you has been to introduce this technique in your practice?
That's a very good question. I have to say that I have a large background in edge-to-edge repair. So definitely edge-to-edge repair in the tricuspid side helped me a lot to understand the movements of the device, the position, how to orientate myself, because at the end you have to, although it's an easy procedure and cases nowadays are highly selected, still you have to play with the device, position in the right place. So having the background of the tricuspid edge-to-edge technology for me was fundamental to rapidly and easily adopt this new technology.
And finally, Neil, I know you've been playing with different devices. You should expect this question. So what is CardioValve advantage compared to the competitors?
So CardioValve is more forgiving. As Rodrigo alluded to, you do not have to capture every single segment for it to be stable because it has more than one mode of fixation. It's not just a leaflet. You have an atrial flange, which will seal PVL, and then it self-expands. So I think you have to capture the leaflets. You can get PVL, but it's a bit more forgiving than some other devices. The other signal is the pacemaker does not seem to be very high, which is also, I think, an important thing for patients.
Yes, probably because it's less related to, there is less need for oversizing, because the way you fixate this valve is not only related to oversizing. Yeah, so unfortunately we're running a bit late, so I think unfortunately I need to close this first session on the tricuspid valve, and some of you is going to leave. I think Felix, Georg, you leaving, also you, and we stay. Okay. You stay as well?
Sure.
All right, so, and I'd like to ask Dr. Qureshi, Duong Bateau to come and to run the second step of the session. It's obviously for us becoming, I start to be uncomfortable because the pulmonary valve is not our daily piece of cake, although I have to say I already had a couple of patients I've been treating very happily so with this device. And having said that, I'd like to give the word to Professor Qureshi, who will share with us the European experience today with the Venus P-valve.
Thank you very much. I'm grateful for the invitation to present the data on the European study. These are my disclosures. Just a brief overview of how Venus P-valve, the pulmonary valve side, has developed. Back in 2009, the engineers developed the Venus P-valve, and then in May 2013, the first Venus P-valve was implanted in China. And October 2013, in Bangkok, that was the first P-valve outside of China. And I was involved with that. And then July 2014, we did the first outside of, the first one in Europe. And then August 2016, the first patient was enrolled in the CE study. And as a result of that multi-center study, in April of this year, CE mark was given for the Venus P-valve. So the Venus valve, originally, the top picture really shows you the original modular design, which had 3 sections sutured together with surgical sutures. But the bottom, the unibody design, and in bottom right in particular, is the current valve, which is a single nitinol tube with a distal flare that is uncovered. Oh, I need to go back. Okay, never mind. The distal flare is uncovered, and the proximal flare is covered. So the technique involves obviously just checking that the femoral venous access is appropriate and good size, because later on we will need a big size sheath. Then we usually get usually left pulmonary artery approach is the best one, but it depends on the anatomy. And then once we've got a good stiff wire, such as the Lundquist wire in the left pulmonary artery, we then use balloon interrogation and determine the size of the valve that might be required. We sometimes do both compliant and non-compliant balloons and make a decision. It depends on the anatomy, of course. And then the right-hand picture, you see the Venus P-valve in position. Majority of cases, we use the left pulmonary artery approach because it's a straighter run from the right atrium, right ventricle up into the left pulmonary artery, whereas you can see in many patients, the right pulmonary artery will have a fairly sharp angle and present with different challenges. In this particular case, the distal flare, the uncovered distal flare, is exposed in the left pulmonary artery and gradually withdrawn into near the bifurcation. And the picture on the right shows the distal flare more widely open at the bifurcation. Check angiograms are performed frequently in both projections before the final decision is made to fully release the Venus P-valve. And there's the right ventricular angiogram in the middle and the pulmonary angiogram on the right, showing a good position of the valve with catheter-induced some pulmonary regurgitation. And then removing the carrot or the delivery systems also can be challenging. So you have to be really very cautious in removing the carrot in particular. The CE study, myself and Ziad Hijazi were the main PIs. Kubir and Pushparaja from our unit was the core lab imaging assessor, and the 3 safety board members consisted of Mario Carminati, Ina Michelle Benker, and Martin Witzenberg. And there were 83 patients evaluated, of whom 79 were considered suitable for Venus P-valve implantation, and all 79 of them had successful implantation, and then they were followed up at 1 month, 6 months, and annually thereafter. The primary endpoints were occurrence of death or reoperation at 12-month follow-up, occurrence of major adverse events at 1-month follow-up. And these adverse events consisted of either death, myocardial infarction, need for reoperation, vascular injury resulting in vascular graft intervention, stroke, and pulmonary embolism. And performance was evaluated by, firstly, successful implant of the valve, and then hemodynamic performance measured, assessed by Doppler gradient across the pulmonary valve on transthoracic echocardiogram at 1 month. And of course, abolition or improvement of pulmonary regurgitation. And then we evaluated structural valve dysfunction or deterioration in terms of stent fractures, leaflet mobility and thickening and calcification at 6-month follow-up. The inclusion criteria, we were fairly rigid in having patients that were between 12 and 70 years of age, and the weight was really determined by the size of the sheath that was required, so we stuck to 30 kilograms or upwards for inclusion. There had to be evidence of moderate or severe pulmonary regurgitation on transthoracic echocardiogram, and MRI was the really mainstay of our indications. Pulmonary regurgitant fraction of more than 30% on MRI, or symptoms from the pulmonary regurgitation, or MRI criteria fitting for intervention such as end diastolic volume of more than 150 mils per meter squared, pulmonary regurgitant fraction of more than 30%, and right ventricular ejection fraction being reduced at less than 45%. There were the usual exclusion criteria such as previous endocarditis or active infection in the at least 4 weeks beforehand, chest wall deformity, vascular access issues as well. Now, patients were enrolled in 10 different sites from Taiwan and Hong Kong in the Far East to Bangkok to Doha, and in Europe, Germany and Belgium, in UK, Leeds and ourselves, and in Dublin, and then Brazil in South America. So the age range was between 12 and 65 years, mean of 26, just over 26 years. Weight range was 34 to 106 kilos, with an average of 59 kilograms or thereabouts. There were some patients with additional diseases such as hypertension or diabetes, but the majority were tetralogy of Fallot or pulmonary atresia with VSD, or pulmonary stenosis with ASD or VSD previous repairs. The important thing to note here, this is the distribution of the different valves that were used in the study. 84% of the patients, 66 out of 79, received a venous P valve that was more than 30 millimeters in diameter, and that really shows that we're dealing with the larger end of the spectrum for which the other conventional valves that have got CE mark were not really suitable. All 79 patients had successful implantation. There was no mortality at 6 months, 12 months, 2 years, 3 years follow-up, and there was no need for reoperation for any reason up to 3-year follow-up as well. There were a few adverse events, some important and some just for completion we included them. There was pleuritic chest pain in one patient on day 2. There was wide complex tachycardia at 1 month almost after venous P-valve implantation. And the same patient then, after the initial treatment, required VT ablation about 5 to 6 months after the venous P-valve implant. And there were other adverse events such as anal bleeding, hemorrhoids, problems like that, which required hospital treatment for various things. But endocarditis, there was one patient, and I'll come back to that, and valve thrombus in one patient, and I'll come back to that. More importantly, you'll see that the vast majority of patients had either abolition of pulmonary regurgitation or had improvement down to either mild or trivial pulmonary regurgitation. So we achieved that endpoint. Another important factor is the right ventricular remodeling. So on the left, you see the end diastolic volume indexed. The mean was 157 mils per meter squared, and at 6-month follow-up MRI, it had reduced to 116 mils per meter squared, and again, very encouraging. The third graph chart on the right shows the pulmonary regurgitant fraction reducing from a mean of 43% before the venous P-valve down to 3% afterwards. There was no change in the ejection fraction but the end systolic volume also improved. We looked meticulously for stent or strut fractures, and there were 11 out of the 79, so 14% of patients had strut fractures. These were all, majority of them were single strut fractures. There were 1 or 2 with 3 or 5 fractures, and pretty much all of them occurred at the right ventricular main pulmonary artery junction in the proximal flare region, because that's the contractile part of the right ventricle compressing the struts. Focusing a little bit more on some of the events. Endocarditis, this was a single patient, age 17 years, had 3-week history of fever about almost a year after the venous P-valve implant, and blood cultures were positive. Received antibiotic treatment for 6 weeks, and the vegetation resolved, and the valve is still in situ 3 years later with very mild pulmonary regurgitation, but a well-functioning valve otherwise. Valve thrombus, there was one patient in whom 8 days after the implant, on routine check, although there was no fever, the leaflets appeared to be slightly thickened. This was one of our patients, and the Doppler gradient had increased to about 25 millimeters of mercury. And so we treated it as if there was microthrombi deposition in the leaflets with heparin and then addition of clopidogrel to the aspirin for 6 months. And that, interestingly, the gradient resolved and the valve has remained functioning well, and the patient is maintained on aspirin only. Another one, 3 years after venous P-valve implant, aged 18 years, echo on a routine follow-up showed an echogenic mass at the proximal right pulmonary artery near the distal flare of the valve, so probably attached to the distal flare. Blood cultures were negative, so there was no evidence of endocarditis. This patient was treated with initial heparin and then addition of warfarin for 6 months, and then subsequently aspirin, and the thrombus was resolved and the valve is still in place. Arrhythmia, very important. This patient was a 46-year-old, 4 weeks after venous P-valve implantation, presented with ventricular tachycardia, which needed resuscitation, DC shock, amiodarone, and so on, and subsequently had VT ablation and an ICD implant. This patient, in retrospect, had in another center had been monitored for arrhythmias and was not really on treatment, but they had raised this for a few years before the valve was implanted. So the venous valve is still in situ and functioning normally, but obviously the arrhythmia, the substrate was present, and the venous P-valve then probably made additional contribution to it. So just to finish up, venous P-valve has improved right ventricular remodeling, has improved pulmonary regurgitation. Pretty much all the patients have less than mild pulmonary regurgitation at up to 3-year follow-up. So far, there's excellent 3-year safety, no mortality, no reintervention. So we've had satisfactory results with excellent long-term performance, safety, and efficacy. And that's just on the CE study. I've been implanting this valve since 2013 now, so we've got 9-year data outside of the CE study, and pretty much all the valves are functioning. They're still in situ. There has been one valve that's been explanted overseas, and that was when the patient was undergoing tricuspid valve repair about 7 years after the initial venous P-valve implantation. The surgeon decided to take out the venous P-valve because they thought it would at some stage need replacing anyway, so they took that out and replaced it. But the valve looked macroscopically as well as histologically excellent, even at 7 years. So it's very encouraging. This does meet an unmet need because the larger outflow tracts are very difficult to deal with, and the patients will then require surgery, and we're able to deal with these here with the venous P-valve. I'll stop there. Thank you very much.
Thanks a lot, and we move to the next lecture on patient selection, which I think is obviously very important. Dr. Duong, please.
Thank you very much for the opportunities. My name is Fu Dong. I'm an imaging cardiologist based in Liverpool, United Kingdom, and it's my great pleasure to share with you the knowledge along this whole journey with choosing the correct patient for venous P assessment implantation. Currently, I'm doing this work to support Venus MedTech Europe, and also previously I've had research bursaries from both Venus MedTech in China and Europe as well. So if you're like me, who's a congenital cardiologist, you look after 1 in 5 patients with the right outflow tract problems. So this is the majority of them have a diagnosis called tricuspid, which comprises a majority of these patients. So 1 out of 5. And then with the survival surgery throughout childhood, we expect these patients to live right into adulthood and have pretty much normal life expectancy. During this whole course of lifespan, each of these patients probably have about 2 to 3 additional open heart surgery. So it could be, fair for this patient to not having any products that are similar to other valve products that are available in the market. So with phallotrichology, the majority of these patients have a very, very large outflow tract, and recent analysis shows that about over 3/4 of these patients are actually not suitable for some of the conventional valve products prior to the launch of Venus P. So it couldn't be the correct timing. The timing couldn't be any better. So just to show you some of the intrinsic differences between what we call a conduit RVOT, so these are valve that's been modified with a conduit, whatever type it is, with or without a valve, a metal valve ring in there, versus a native, which is in quotation marks, because the majority of these tissues have been preserved. And you can see the differences. One has a clear waist for your landing zone, and the other one is very, very distensile, very contractile, which is almost very, very hard to plan, because I don't know what size it's going to be, how a valve is going to be sitting in there and not being milked away or pulled backwards. Very little anchoring points, and the lengths are variable in these patients as well, and with numerous morphology. So prior to the procedure, as we learn from our experience, and CT and MRI are great modalities to assess this patient, to ensure that you advise the intervention team the correct substrate of patients, because getting this right is more challenging than other products. So you can do dynamic images or static images, MRI of various sequences, 3D, 4D, multiplanar, various ways to assess and choose the right substrate. CTs recently equally come along quite nicely, especially with motion resolved CTs. You can have the really nice profile of the outflow tracts all the way into the branch pulmonary arteries, and clearly delineate any of the additional problems along the way. So majority of the cases can be planned well ahead. So for me, in order to advise an intervention team as to what is the best thing to replace the pulmonary valve, we don't just look at the actual valve, the defective valve, because we know it's going to be wrong anyway. But we need to study the access, specifically, you've got big sheaths, 20-odd French sheaths, going all the way from the IVC, RA, through the crossover tricuspid valve, navigate a 180-degree bend to the right ventricle body and go all the way to the branch pulmonary arteries. A lot of that path has to be planned and ensure that the best approach is done correctly. We need to look at the whole morphology of the outflow tracts, the main pulmonary artery and branches, all of those details particularly. And it couldn't come at a better design for this valve because it conforms nicely all the way from the outflow tract to across the valve to the main pulmonary artery, and the flares right into the bifurcation without blocking access to the branch pulmonary arteries. And it fits the majority of the patients, as you saw, 3/4 that couldn't fit with the prior products before. So a lot of work needs to be done in terms of planning. So I look at the shape of the outflow tracts, look at the size, look at the length, look at the branches of the pulmonary arteries, look at the coronaries and any additional things like pacing wires or defib sets. The textbooks show us that there are about 5 different kind of representative shapes of outflow tracts, which is shown on the top rows. But in reality, you can see that directly below them, that's the equivalent closest neighbor, to the shape, and you can see that they look completely different, and there's not a single one patient that I see actually like the previous ones. So careful assessment is needed. To get the size of the valve is challenging in this patient because, as you can see there, how distensible the tissue is all the way from outflow tracts to the branches. The length of that also matters, and as you can see, shorter length will just does not encourage, provide enough tensile strength for the valve to sit nicely. The branch pulmonary arteries, as Professor Qureshi has highlighted, that you need to have nice passage of the wire, least torque, and also where you saw an example where the distal flare was deployed from the branch pulmonary artery and withdrawn backwards. So then all of this needs to be factored in the planning stage. So choosing the PA approach is important to your success. Also the landing zone, in this case, that's the picture that the mid-lower zone line there, you need to implant it fairly distal into it. And then the pictures on the left-hand side probably not suitable for implanting due to irregular shape, but also the branch pulmonary artery problems, which needs to be intervened upon as well. Coronaries, increasingly we're dealing with an aging group of patients, so you need to be aware of potential compression as well. And despite all this, in non-invasive planning, there's certain things that a non-invasive procedure cannot resolve, which is actually putting a balloon in and then get the correct size and also resolve some of the narrowing that potentially make way for a nicely compliant valve sitting in there and conform and perform a good function. So all of these testing exercise, once you've got a nice shape, you've got the nice morphology, you can plan your catheter. And then, the key thing is tissue compliance. As you can see there, one example, this patient's got calcification, and where the patch was applied, some of the valve tissue has been resected. The patient's young, so it's very distensible, MPA and the branches distally, and also there's a fold in the distal PA as well. Those are the kind of thing that need to be factored in terms of planning, because you need to plan the valve is so big, the outflow tract is so big, there needs to be room to recapture, reposition, and then ensure that it's sitting perfectly right. So this is how we do our assessment process. We do lots and lots of measurements and try to correlate different areas and match them to one another. At the moment, feature tracking isn't quite there yet, so a lot of this work has to be done manually. So we measure the lengths at different diameter and at different levels, from subvalvular, valvular, supravalvular, mid and distal branch pulmonary arteries, work out the differences between systolic and diastolic phases, estimate the differences, what these numbers would mean when you put the balloon in there and interrogate the outflow tracts, and then work out the size. And currently we oversize by +2 to 4 millimeters from the maximum area where the balloon and also non-invasive imaging advice as well. This case was done, that last case was done at PICS this year and showed good success. The compliance also, you can see that based on, as an interventionist, when you receive this report, you see that there are differences between the curves between the two cases. That advise you that the cases on the right-hand side is a lot more compliant in terms of the morphology and the soft tissue compared to the left cases, where the chronic distension has entailed based on all the multiple level of obstruction. We also use virtual reality to mainly for education and for planning and some of the complex morphology. In this patient, you see that the heart is in the wrong place, the apex in the wrong place. Patient also have an aneurysm from the outflow tract as well. So it's good to understand the mechanism of the aneurysm, so you can plan, you can measure, and you can actually overlay some of the valves that kindly being provided by the company. So those are true samples, so you can have better understanding. We don't advise sizing based on this because it needs further validation, but at least it provides a good understanding. And just to finish off, some of the work that's come along very nicely with the collaboration between Venus MedTech and FEOPS and supported kindly by Professor Qureshi and Professor Junbo Ge in China, who's the main PI of the Chinese study from the early stage, where we would like to develop a platform where the interventionist can actually interact with the data set, use computer modeling, finite element analysis, so you can actually plan to choose the correct sizing, correct landing zone, and also contact forces, and also plan your catheter access as well. And our work has shown that the validation has been pretty spot on. As you can see, that each of those dots is a measurement of each level, and it has very good correlation coefficient based on different ways to analyze this. So to close it off, patient selection is extremely important if you want your program, and the best fit needs to be chosen due to the anatomic variation, and also bear in mind the case planning with the sheath passage, how you can fine-tune the position of the valve and repositioning, get a good landing zone, and essentially, despite being independent, but I think this is probably the best suited valve for the dilated outflow tracts that's available in the markets right now. Thank you.
Thanks. And finally, we go for a real case. So we are all eager to see how this valve works in the real world. So Dr. Batte from Paris, correct? Oh, where is Paris?
Yeah. Dr. Batte, Clément, from France. So thank you very much for giving me the opportunity to present this case I made with Dr. Asquet in Maryland Long Hospital. So this is a 72 years old patient which have a tetralogy of Fallot, and she have been operated long time ago by a Blalock toxic shunt. And then at 25 years old, she had a complete repair with a transannular patch. So she was lost, and she came back in the hospital many years after with the expected evolution of this disease, which is a massive pulmonary regurgitation, right ventricular dilatation, and RV dysfunction. So in the MRI, she had a clear indication for pulmonary valve replacement. So when you look at the cardiac CT, you can see that the shape of the RVOT is tubular. The coronary arteries seems to be far away from the pulmonary trunk. And the branch anatomy, the LPA and RPA are very specific. It's not a usual disposition that you have the RPA, which is rising alone, and then the LPA, which is going down. On the preoperative catheterization, you can see that there is a massive pulmonary regurgitation, and the RVOT is really large. We have asked to Dr. Duong to do the measurement. So this is a 72 years old patient. She had a lot of comorbidities. She has a high mortality risk if we propose surgery. That's why she was turned out. And she is unsuitable for conventional percutaneous valve because the diameter of the RVOT seems to be too large. That's why she became our first patient who had a Venus P valve in our tertiary center. So we made it in August with Dr. Asquith, and we were proctored by Dr. Jamie Bentham. So in this slide, it's important to see that we work on a biplan, so we need the face and the profile systematically, and we always use for a pulmonary valve implantation Vessel Navigator software from Philips to have a multimodality fusion imaging guidance. We have already seen this large RVOT with the massive pulmonary regurgitation. And we know, before choosing the valve, have to assess the distensibility of the RVOT by balloon testing. So the first balloon testing is with Amplat sizing balloon, which is a compliant balloon. And you see here that there is a waist where the pulmonary valve was before, around 27 millimeters. But adjacent diameters are very, very large. So we have to make another balloon testing with a semi-compliant balloon, Taishak 30 millimeters. And here you can see that there is no valvar restriction anymore, and the diameter is around 32 millimeters. This testing permits us to do coronary testing at the same time, and we can see that the LMCE is really away from the RVOT. So we will choose, for this case, the Venus P valve number 34. And you can see in red that there is landmark on the valve that you can see on the angio. And you can see also that there is two proximal hairs that will permit to fix to the valve to the delivery system. So there is a big time for washing the valve in cold water. You need at least 5 baths, and in total more than 15 minutes. And then you will have to crimp the valve. It's not cold water, but iced water. You need ice to make the valve going inside the capsula after having attached the two ears in the capsula in the delivery system. So after this process, you will bring a dry seal 26 French from the right femoral vein to the LPA in this case. You are stabilized by a backup Meyer wire, and you have to put in parallel a pigtail. In this case, because there was a risk of RPA occlusion, we put a pigtail to make an angiogram during the valve positioning and deployment. Here you can see that the valve is far in the LPA, and then you will retrieve slowly the dry seal and then the capsula between the two landmarks. And so the valve will go from the LPA to the MPA. And there you will have to be aware about jump back effect. So you have to push a little bit on the sheath, not to make the Venus valve too low. When we see the deployment from the LPA to the MPA in B view, you can see that when you are retrieving the sheet and the oliva, the capsula, you will have to do it very slowly and to wait for the valve to warm up in the MPA, and slowly, with patience, the valve will take its final distal shape. After that, when you are satisfied of the distal position of the valve, you have to retrieve first the dry seal and then the capsula. And then for the final deployment, you will retrieve the capsula close to the dry seal. And the valve will take her final shape. Then you have to be really aware about a retrievement of the delivery system, because you cannot attach it to the valve. It can lead to embolization of the valve. And before leaving the backup Meyer, you have to control by a RV angio, which seems to be satisfying. And then we made angio in the right pulmonary artery, which is really patent, and there is no pulmonary valve regurgitation anymore. On the day 1 TTE, you can see that there is no pulmonary regurgitation, no significant gradient. The valve seems to have a good shape, and there were no extrasystole. So as a conclusion, the Venus P valve is a new solution for a large RVOT, especially in a patient with tetralogy of Fallot operated long time ago. The maximal diameter in real life can go around 44 millimeters. It's a good alternative to surgery in selected cases, and there is promising middle-term outcomes in publication. Thank you for your attention.
I don't know about soccer. We Italians, we don't watch soccer anymore.
No more.
So in sake of time, because we are a bit later, I would like to ask Scott to give an overview to the audience of the pipeline of Venus MedTech.
Sure.
Which is, obviously we have seen outside, the objective is to become another big player in the market. So let's see what is the pipeline.
Or at least I'll tell you about those that I had the opportunity to be involved with on the early stages recently as last week. So disclosures. And Venus now has technology approaching all 4 valves. You just heard obviously about pulmonary, and before then we were also looking at cardiac valve replacement for both tricuspid and mitral. But they also have repair technologies as well on both mitral and tricuspid, and other replacement stuff, which I'll tell you about briefly. And these are the 3 that I've had some involvement with, and as recently as the other week for some of these, which the first one, both PowerX, and the second one, Vitae, are transcatheter replacements, and Dragonfly is repair technology. On the replacements, one of the first things is that the technology is advanced, so they now incorporate dry tissue technology, which really helps from a logistics standpoint. It's also how the valves are prepped. It makes it very quickly to flush and then hand it off to you to go ahead and deliver it. Also, it has anti-calcification treatment for durability issues, as well as reducing the amount of glutaraldehyde you or your staff have to play around with or be sure to flush off. The Vitae or PowerX expands on Venus's platform of self-expanding valves that have stronger radial force, particularly to deal with the higher calcium burdens in aortic stenosis, particularly in a Chinese population. But there still is the recognition of the need of a shorter valve, and that's where the one on the right, the Vitae, comes into play, and I'll tell you about both. So in terms of PowerX, it's that latest generation of self-expanding but fully recapturable and retrievable as well. And it comes in a range of sizes like we've seen with the previous generations of Venus A valves, from 23 all the way up to 32 millimeters. As I mentioned about the leaflet technology, it also has the openings of the stent frame are designed to allow for coronary access. The other key parts is all on the delivery system. As I mentioned, it can be fully deployed, but you're still holding on to it. And just the other week in Argentina, we were able to do that and then fully retract it if you don't like your position, or we did it in a case of very limited amounts of calcium, and be able to have that security of placing it exactly where you want to. It also has the ability to rotate it for commissural alignment. The very first case was done in China by our colleague and friend Chen Mao, and similarly is able to deploy it and be very secure about its positioning, and if you were not happy with it, to adjust that positioning, as you can see here. And again, our colleagues in China tend to deal with much higher calcium burden in their aortic stenosis, and this has a very strong radial force to this valve. The next valve in the pipeline, as I said, is a balloon expanded valve called Vitae. It's relatively short frame. So again, thinking about the long term and these patients that have lifetime management needs for the aortic stenosis. The delivery system itself has a lot, as you can see on the right, a lot of different functionality to it, so that it is covered with a capsule going into the vasculature. You can articulate it in multiple directions, including rotation, again, for commissural alignment. And it has a very unique locking wire release, so it doesn't get positioned or it doesn't slide off your balloon one way or another way till you're ready to deploy it. It comes in what the Venus calls a G sheath, has an expandable sheath. So for those of you that are familiar with the Gore dry seal technology, this in my mind is a step up. It has a spring piston mechanism and also comes in longer length. So if you've got a taller patient, even you're deploying the things in the pulmonary position, this type of technology can be very helpful. And so here was one of the examples. This is a case we did back in August, and we did a series of about 7 of these on the aortic position. As you can see here, this was a 26 millimeter valve. We were able to do this relatively quickly in 25 minutes and in a very horizontal heart, but we were able to articulate this to be able to land it appropriately there. This patient also had a fair bit of aortic regurgitation and not the greatest amount of calcium, as you can see there. And then we just got quicker too with this. This case was done in just under 20 minutes, as I recall. Very straightforward delivery and very secure positioning of the valve on the balloon delivery system. And again, short frame valve, so preservation of coronary access, also making it easier for someday if you have to revalve this. So here's where things are at in terms of different clinical trials for the aortic valve technologies. PowerX finished now in China and Argentina, early feasibility and first in man. The data will be presented shortly. We just presented the data on Vitae in the aortic from Argentina, first in man series. We're just about to at ICI. And then you can see as we then plan to take this to Europe, with these technologies as well. Switching gears a little bit to mitral and tricuspid, the other thing coming out is the Dragonfly device. As you can see there, it's a tier technology, but with some differences. So grabbing not just leaflet to leaflet and pulling them together like, say, a MitraClip would do, but leaflet to leaflet and pulling it to a compressible central filler. And you can also control how much you bring the two arms and therefore the leaflets together. As you pull them closer to that central filler, that filler then, because it's very distensible, as you can see here, then can distend out on either side, filling more of the regurgitant orifice. Here's examples of doing just that in a case, trying to aim again for 0 to 1 plus residual MR. And even, granted, this is an animal study, but we found when we sacrificed the animals at later time points, even after you had tissue ingrowth into the filler, you could still reach in with your hand, and it's still very compressible, very flexible, and that's mirrored by what we saw if you just step on the fluoro. You can see the deflection of the device and the tissues, opening it greater in diastole and closing greater in systole. And that's mirrored by these outcomes with progressive decrease or elimination on the MR, as we've seen in actual patients, as you get ingrowth into that filler. Comes in a variety of sizes, including even the extra large pro sizes, which we started using more on the tricuspid side of things. And this gives you a sense of that size range in comparison to other technologies, that therefore I think this makes this different and gives us, physicians-wise, more utility in approaching different diseases. The delivery system also is somewhat different. It's sort of like, rather than all your other tier technologies is like you're tightening the cables. Here, it's more like index shifting, how bicycles now are doing shifting, and you can click, click, so many turns, and you can almost come up with a flight plan to a given patient's anatomy. You know 4 clicks on the big sheath, 3 clicks on the middle sheath, and then you're there. And that hopefully will allow this to be more teachable in a repeatable fashion. So we've finished already a number of clinical trials with Dragonfly in China. We've even presented at last TCT the early feasibility study. The DMR study is completed enrollment. We're waiting for the final data release. FMR trial is continuing enrollment, as is TR, and we're just in site selection now for the European MR study with Dragonfly. As you can see from the early feasibility results by an echo core lab, these are very good results. Essentially what we're seeing similar to other TR technologies. So with that, thank you, and hopefully I was quick enough to get everybody out to dinner soon.
Thank you, Scott. I think it's time to wrap up this session. I want to thank everybody to join us until late today. It's been a very long day. We have been learning about these new technologies with a lot of interesting features which are really filling some of the gaps in current available technologies. I think the world is moving forward, and we will see these devices coming into our practice in the next few years. And I think this is another step to get much better results. Having said that, thanks very much for your attention, and see you tomorrow.